Good morning, everyone. This is Chelsea Schwartz from the Health Quality Council, and we're officially getting started now. So welcome, everyone, to QI Power Hour. If this is your first time joining QI Power, a very special welcome to you, and it's a great time to join. This topic has proven to be one of our most popular QI Power Hour sessions to date, so we're very excited to get started here. So before we get started, we just want to take a moment to recognize that Health Quality Council is located here in Saskatoon on Treaty 6 territory on the traditional land of the Dakota, Lakota, and Nakota, and homeland of the Métis. As an organization, we are committed to learning from the history of this land that we call home and move forward together for better health for all the people in Saskatchewan. We invite all of you to take a moment to also consider where you're joining us from here today and reflect on the intentions that you individually and collectively have to create meaningful change for where we live. So for those of you who are new to QI Power Hour, I just wanted to take a moment to introduce you to this offering. So it's a free monthly webinar hosted from the Health Quality Council here in Saskatchewan. We bring together improvers from a variety of sectors with an interest in improving health to learn about quality improvement related topics. So we do invite you to check out our website. For those who have colleagues who weren't able to join us in person here today, all of our sessions are recorded and then posted to our website following the session. So we invite you to take a peek at past webinars that are stored there and to forward this recorded session on to those who aren't able to join us today. While you're on our website, we do invite you to sign up to our distribution list so that you can receive regular invites to all of our upcoming QI Power Hour sessions. So over the past number of years, we've been really excited to see the continued growth of QI Power Hour throughout our home province of Saskatchewan, throughout the rest of Canada, and in fact internationally. So thank you to everyone who is taking the time. We know that everyone has busy schedules. So thank you to your commitment to your ongoing learning and your commitment to improve each of the systems that you're each part of. So before we launch into our session today, we have specifically designed this session to be highly interactive. So the speakers today really welcome your participation and your great questions throughout the session. In order to do this, we're going to make use of the chat function. So I just want to spend a quick moment here on how you can access that. So you'll notice that there's a toolbar at the bottom of your screen. So if you see the chat message bubble that appears when you hover over it, you can click on that button and this will launch the chat to the right-hand side of your screen. So we do encourage you to, in your toolbar there, to make sure that you have selected all participants, just to bring everyone along in the conversation and so that we're all seeing the questions at the same time and being part of the same conversation. So I'm going to invite everyone to take a quick moment to test out that chat function by writing the name of the organization you're joining us from today, as well as the location that you're joining us from. So what we've noticed in the past is now that we've moved to one single health authority, we see lots of SHAs coming through, but that doesn't tell us much about where you're joining us from. Great. It looks like we have people who have found the chat function. Excellent. Welcome to those joining from Regina, Saskatoon, Prince Albert, Regina. Perfect. Welcome, everyone. So feel free to make use of that chat function throughout the entire presentation. We will be collating the questions as we go, and we'll kind of get to as many as we can during the duration of our presentation. If we don't get to your question, we have some instructions on how you can access the answers that you need following the presentation. So the next way that we invite you to take part in the webinar today is through Twitter using the hashtag QI Power Hour and the handle HQCSask. And so with that, I'm delighted to welcome our speakers today. We have Dr. Kevin Wasko, who's the Physician Executive of Integrated Rural Health, working out of Swiss Current. In this role, he works in a dyad relationship with Karen Earnshaw, the Vice President, to co-lead the clinical services delivery in the southwest and southeast areas of the province. One of the exciting new infrastructure developments in the establishment of the new SHA has been this introduction of the dyad model of leadership, So for each clinical services portfolios at the executive level, there's both an administrative and a physician lead who partner to oversee the operations in that portfolio. Dr. Wasko is the executive sponsor for the Health Network Development, which has been a key strategic initiative of the SHA. Dr. Wasko has worked as a family physician in both Swift Current and his hometown of East End. He continues to work clinically in the emergency department in Swift Current. So welcome, Dr. Wasko. Next, we have Sheila Anderson, who is the Executive Director of Primary Healthcare in Regina. Sheila has 25 years of healthcare experience in a variety of roles, including 10 years experience specifically in quality improvement, system change, and managing large-scale regional change initiatives across the former Regina-Capel Health region. She has experienced establishing the first health networks in Regina and is now the operational planning lead for the establishment of health networks throughout the rest of the province. Welcome, Sheila. And joining us for the Q&A portion of our session today, we have Dr. Rashaad Hansia, who is the Executive Director of Integrated Urban Health, working out of Regina as well. And the reason Dr. Hansia is joining us today is that he previously served in the role as a physician dyad lead with Sheila and took part in the establishment of health networks in Regina as well. So he's now newly serving in the role of physician executive of Integrated Urban Health. Welcome, Dr. Hansia. So with that, I will pass it over to our speakers this morning to get started.
Okay, thank you, Chelsea. So just before Sheila and I get started with a short presentation, and it is going to be pretty short because we do want to hear from people about the questions that they have about health networks, and hopefully by the end of this session, everyone leaves with a better understanding of what this initiative is. You know, it's really great to see so many people that have registered for this. Chelsea was telling us yesterday that we actually have a new record for the amount of people that have signed up for a QI Power Hour. That tells us that there's a lot of interest in this and a lot of interest in the changes that are going on in the health authority. And as many of you know, we're almost at the 2-year mark of the SHA. It's hard to believe it's already been 2 years, but a lot has been going on in those 2 years in terms of setting our new direction. But one of the main changes that we're seeing is the establishment of health networks and the work that has gone on to do that over the last 2 years. And really what this marks is a fundamental change in how the SHA will function and its commitment to designing a health system that shifts away from reliance on acute and specialty care to one that invests in and strengthens the everyday health services that people need. And that's really what we hope health networks will help us to achieve. Health networks are collaborative teams of health professionals, including physicians and community partners, providing fully integrated services to meet the health needs of individuals and communities. And because we know that communities are not all the same, health services in each network will also be different, and these differences will be determined by local needs through some of the data that we're collecting and also from local input from our physicians and other health professionals, our patients, our families, and our community leaders. And health networks are being developed and co-designed with health system partners. So this is truly co-designed. We have a tripartite leadership of this with the SHA, with the Ministry of Health, and with the Saskatchewan Medical Association. But there's also been partnership with the Health Quality Council and eHealth to try to bring all of the health system partners on board to drive this initiative forward. Oh, Sheila, you're on mute.
Can you hear us now? Good morning.
Yes.
Okay, thank you. Good morning, everybody. Welcome to the Power Hour. Kevin and I have thought that the best way to help people understand what health networks are is through telling a patient's story. So the presentation we want to share with you today is called a Pecha Kucha, and some of you may be familiar with it. So it's a presentation style where you tell a story in 20 slides, and with only being able to speak to each slide for 20 seconds. So it's quite a quick presentation. It'll take only about 10 minutes or 15 minutes, which will, as Kevin said, allow us to have lots of time and discussion, lots of time for discussion, and to get into more detail about Health Network. So the presentation we're going to present to you is the story of Jack.
Sorry, Dr. Wasko, we'll unmute you. You're unmuted now. There you go.
Yeah, it keeps muting me. Okay. So this is a story about Jack. He could be you, your father, a friend. He's been feeling unwell for a number of weeks, but couldn't get into his family physician. So he presents to the local emergency department, as many people do when they don't know where else to go. He is eventually diagnosed with diabetes, started on medications, and told to follow up with his family physician. When Jack gets in to see his family doctor, the care he receives is excellent. His medications are changed, and he is told that he will be referred to a dietitian and a nurse educator so that he can better manage his disease. And he should hear from them in a few weeks. The physician's office faxes referrals to both the dietitian and to the educator. The physician has never met either of them. He doesn't know that the dietitian is away on leave, and the fax never makes it to the nurse educator. In the meantime, Jack has really good conversations with his pharmacist about the new medications that he's on. And he seeks out information about checking his blood sugars from the Canadian Diabetes Association. But no record of these encounters is ever looped back to his family doctor. Jack's daughter begins to worry about not hearing about the referrals and becomes her father's advocate. She calls the clinic and requests that Jack be re-referred. He eventually does see the dietitian and the educator, and he gets some really good advice, but there's no connection back to the other members of his care team. Jack's story is not unique. We currently have a system of silos that provide excellent care but are not interlinked. Patients feel lost in the system, and health professionals feel disconnected.
Now consider a model where Jack has a team of healthcare providers, including physicians, nurses, and community partners, all working together in a health network to provide coordinated care. The services of the network would be designed to meet Jack's healthcare needs, and Jack would get his diabetes care where he needs it and when he needs it. In this model, Jack would not have to individually contact separate providers or tell his story over and over. With the support from his team, Jack would feel confident and empowered to manage his own health, like eating healthy and testing his own blood sugar. Both Jack and his daughter would know how to call the local healthcare team for help and would feel confident that they would be safely navigated through the health system. Because Jack is getting consistent, high-quality care, he would not need to rely on the services of the emergency room to manage his diabetes. All members of Jack's healthcare team would be connected through an electronic medical record. The medical record would have Jack's most up-to-date health information, and the team would use the EMR as their source of truth. Jack's healthcare goals would be known and recorded in a shared care plan. Well, that's Jack's story, but that's the story that we hope you hear all across Saskatchewan as we develop integrated teams to better meet the needs of people, no matter where you live or what your circumstance is. Health networks are about building relationships between providers who respect and understand each other, and who work together for a common vision. But most importantly, health networks are about relationships with people like Jack and his family. Health networks are designed to move away from a system that relies on hospital care to one that is anchored in community care. In this model, hospital care becomes truly episodic, where health network teams pull patients back to care for them as quickly as possible.
We know that high-performing health systems have strong primary health care at their foundation, and that is what we want for Saskatchewan. Through the creation of health networks, we'll focus on everyday health services and link those services to both intermediate and complex services in the community, as well as to tertiary and acute care. In a high-functioning health network, a broader health ecosystem will exist in the community that links not only the healthcare providers with patients, but also strengthens linkages with other health services such as education, housing, and social services. Because as we all know, very little about what makes us healthy is determined by the healthcare system alone.
We're in the early stages of establishing health networks. We're focused on creating a common vision and communicating the need and desire for change. Teams are working to know their network by understanding the needs of the community and identifying how to improve services. We've just completed a provincial process where we have used community input, local knowledge, and data to determine health network geographies. 38 health networks will be established across urban, rural, and northern Saskatchewan.
So I'm just going to take a little bit of time to, 20 seconds isn't long, and it was a pretty busy slide, but this health ecosystem concept, and really breaking it down a little bit for everyone, and really going back to what this is all about, and it is about the patient and their families that support them at the center of everything we do. And that's a philosophy that's core to the SHA and core to the health system moving forward. And if we truly want to live up to that, then we need to design our services around the patients themselves. So at the smaller, most local level, there would be a medical home for a patient, whether it's in a community health center or a medical clinic. Sometimes care is provided in the home to people, but it's that place that is that common location where the patient receives everyday health services most of the time. And we do think that that can happen more often than it does in many instances. Currently, we have patients that go around to different locations to receive those everyday health services, and we hope that through efforts to co-locate services, patients can have a consistent place where they go to know that their everyday health care needs can be met. But in order for those locations to really function, we need that healthy neighborhood surrounding the medical home. And that's what we're really focusing on with the development of health networks. It's about what services do we provide in the community that need to be better coordinated? Where do we need people to be working as members of interdisciplinary teams to better provide for the needs of the patients and support those patient medical homes? And as we evolve in this process and get the linkages within the health system more established and the teams working in a more integrated manner, we'll be able to then link with some of the other services that exist in the broader community, such as those provided by human services, community-based organizations, and so on. And I think when all of that comes together, that's when we start to have that health ecosystem where we're really wrapping all the all the services around the patient, from the very local to the broader, in a way that makes sense and is coordinated to better serve the people with problems. So that's our vision. There's a lot of work to go on to get us there, and that's all we have planned for a formal presentation component, and now we're happy to spend the next 40 minutes or so to answer any questions or have some discussion about this.
Perfect. Thank you so much. So we will welcome people to make use of that practice they put into the chat and start asking our good questions in there. I have one to get us started. What some people may not be aware of is that this work stems from some previous work that was a big initiative a couple of years ago in the province called the ED Waits and Patient Flow Initiative. I'm wondering if you can tell folks a little bit more about kind of the evolution of that work and how it's grounded and led into this work.
Yeah, so I don't know if Sheila and Rashaad or I can take a stab.
So I can definitely get started, and please just add in as you wish. I think that there has been and remains a very big focus on reducing waits in emergency departments and improving flow of people through the healthcare system. I think that when that work began, and I won't speak on behalf of the Health Quality Council, but I certainly realized that a lot of that work demonstrated that in order to improve flow across the system and in order to actually reduce waits for people in the emergency department, that a lot of the solutions to those issues were actually rooted in community services. And in fact, the Health Quality Council spent quite a lot of time and resources working on some modeling, working on a lot of literature, searches across the world, in fact, and getting evidence-based information, which was built into dynamic modeling, which showed the impact of various interventions on ED waits and patient flow. And from that work, it was determined quite empirically that actually to address this situation, the best thing to do is to improve community services so that fewer people actually remain in hospital when they don't need to. And those patients who are generally termed ALC or alternate level of care patients actually could be and should be treated more appropriately in their homes with support or in long-term care facilities rather than remaining in acute care unnecessarily. We know that when people stay in the hospitals are fantastic when people need to be there, but anyone who doesn't need to be there actually undergoes potential risk by remaining in hospital unnecessarily. So it really ties in well with the health networks because really health networks are about improving those services, as Sheila and Kevin have said, and we know that if we want to reduce emergency department waits and improve flow, the solution to that is actually building supports, which health networks is all about.
Thank you, Dr. Hansia. So the questions are flowing now, so we're going to take them in order that they appear. Richard Edwards is looking for some more specific examples that the comment that this is a familiar vision, that there's been lots of talk of this over a number of years. Can you provide some additional examples of the steps that we're taking to realize it here in Saskatchewan?
So I can speak to some of the work that's starting to happen is how we structure our community-based services, and some of this work has already occurred in Regina, but other areas are now in the planning phases as to how this would look in any particular community. And I actually think in rural, this has maybe been happening for a while, where we have, rather than siloed off different teams like home care or public health or community-based therapies, all reporting separately and all, like has been said in the presentation, providing really good care to people, we would have more multidisciplinary teams of multiple health professionals working together. So instead of there being a home care department, there would be a primary health care department that would have staff from home care, would have staff with expertise in public health, with therapies expertise, working together on a team defined to a specific set of patients that would work together and link with physicians, nurse practitioners, other primary healthcare providers to really wrap those services around patients. So that might sound like it does exist in some places, but we know that there are actually a lot of divisions that occur between those different community-based services that need to be, melded and reorganized into a way that makes sense around how the patient accesses care. So that's one area, and also there are divisions in terms of the different types of community-based services, but then there are also the whole idea of the division between private practice physicians and SHA-provided community resources, and that's another area where we're trying to create inroads to create common teams, again, based around the patient. So there's work going on there as well.
Great. So one of the questions that has come through the Q&A is this model similar to the accountable care unit at the Regina Pascal Hospital, where doctors and specialists meet with the patients at the same time? Can you talk a little bit about the link between the ACUs?
So I'm happy to to start this discussion. I think that there are very many similarities between the accountable care concept and between health networks. At the root or heart of both of these is teamwork, is physician co-leadership or participation, and is this interdisciplinary approach where all of the members of the team know the patients, know their families, know the needs, and then help to work together to serve the needs of those patients. That is certainly true in the accountable care concept of inpatient care in hospitals, and it's also the very same concept that applies to health networks. It's really a change in philosophy from saying, what service does a person need? So in a hospital setting, that might be, does a person need a physician opinion on this? Does a person need nutrition support? Does a person need nursing services? Those same questions historically applied in community, where people look at it as, what service does a person need? I think the health network concept, which is similar to the accountable care concept, is that we don't look at people and say, what services do they need? We say, what are the total needs of this individual and their family, and how do we collectively as a team work together to meet those needs? So I think, to summarize, it's really similar to the accountable care concept, but really on a different level. And of course, it's very important that part of the connected care strategy, of which health network development is a part of, is connecting in a really efficient, smooth, and patient-centered way the link between community and acute care, so that patients, as was said in the presentation, patients actually are helped to ease between the two episodically when they need to be, in an efficient way that benefits patients.
Great, thank you. Another question from the chat. Understanding this will be a long journey to the ideal health ecosystem, what does implementation success look like in 1 year versus in 5 years? What are those different milestones that you see as success milestones?
I should have had them all in front of me, because we have kind of mapped some of this work out in terms of what our goals would hopefully be in 1, 3, and 5 years. In the first year of this, it's really about communicating the message, getting our teams reorganized into a way that would facilitate like true interdisciplinary care down the line. Some efforts to identify where co-location of health professionals could occur, but placing health professionals together is not going to solve this. There really has to be intentional efforts to build teams and create processes that support that, like huddling around common patients that are complex and whatnot, and getting every member of the team on board for those discussions. Some of that, is all that maybe we would achieve within a year. within 5 years, that's when we hope to really be creating better linkages by that point with those broader human-based services. But in some places, that might be happening already, and in some places, it might be harder to get to that point. So it really is a unique journey for where in the province we're talking about. Like I had said, I think in some very small communities, some of this already happens because the team is so small, and it would be less change than in some of our urban centers where there are a lot of people to get to know, and people are organized right now into ways where staff identify with the department in which they work rather than in a multidisciplinary manner wrapped around particular patients. So that's going to take a lot longer to get eventually to that place. I guess Rashaad and Sheila could talk about, they're 5 years in Regina and what has occurred within 5 years in their sense.
I think that's a really good synopsis, Kevin. I think that as Kevin mentioned, it really depends on where the journey starts, and that will determine where you are in a year and down the line. But it's really, I don't think it's so much about what the pace of that progress is, because I think that everywhere the journey will progress at different rates, at different points along the journey. But I think the concepts are important. And as Kevin said, the first step, and a year is sort of a reasonable arbitrary cutoff for that, is getting teams to start working together. There is a big component of this that is a culture change because, as Kevin and Sheila said earlier on, it really is a fundamental redesign in the way that services are delivered. And in many ways, it's deliberately that, because I think that it's a change in philosophy. And what that does is it allows us to focus on patients, but it also doesn't dismiss how important it is that we work together as providers, whatever discipline we work in. But the downside, and I put that in quotation marks because I don't believe it's really a downside, I actually think it's a strength, is that the teams that we work in are different to the teams that historically we may have worked in. And I think that approach to interdisciplinary care, which is even a step beyond multidisciplinary care, where everyone works to the top of their scope and is able to support each other, I think that is at the root of that. So some places may take a couple of years to get there. Some places may take a couple of months to get there. Certainly, I don't think one ever reaches a point where we say that's done, because it's a continuous process. And so in Regina, for example, this work has been progressing over a long period of time, but it really is iterative, because as people change, as the needs of the communities change, as time progresses, there's always a need to refocus and to adjust what the priorities of the communities are that we're serving, to be able to adapt them. So, for example, 5 years down the line, and this was a question, what does that look like? In Regina, for example, there are now clinical pathways that have been implemented and are being worked on. These are done in collaboration with physician colleagues, both general, family physicians and specialists. They're done with community services. They're done with organizations like Diabetes Canada and the Canadian Thoracic Society, whatever that is. But they really, and they also very importantly include patient and family advisors. So, and all of the other disciplines involved in the care. So 5 years down the line, there could be, as there is here, this collaboration towards developing pathways for care that are based on community needs and that are aimed at delivering the services to meet those needs in the community in a really efficient and effective way. And also, they allow for patients and providers to access services much easier and quickly than they ordinarily would in the past.
Thank you, Dr. Hansia. So it sounds like one of the key ingredients of success, or in some ways a foundational component of this is initial communication out. So one of the questions that we've had is, what is that communication plan to get to primary care providers such as family physicians and traditional medicine practitioners, as well as the public?
So I guess there are different strategies that include getting the communication message out to those groups. There is a physician engagement work stream that will be holding Know Your Network events, which are events that are focused on physicians and primary care providers in the community, and I guess sharing the data about the patient profiles within the network and also the services that exist in the network, and having a dialogue about what should or could exist, and making people aware of that. And those are small group type sessions. Those are starting this month in Regina and then would be rolled out across the province following that. In terms of engaging with community leaders, there will be community advisory networks that will exist, and there have been engagement sessions that have happened in the southeast and the northwest part of the province, I know already, in communities such as Meadow Lake, Broadview in the southeast, and Meadow Lake in the northwest, around sharing this model and this vision with community leaders, and what the network data would say are the issues that impact patients' health there, and then about the services that exist and so on. So that work is starting, but it's also, I think, slow in the beginning because we need to learn what works and what doesn't in those processes and the way in which we engage. I don't know if there's anything more that Sheila and Rashaad you would want to add to that answer.
I just wanted to add that we also, for all of you SHA folks that are on the line too, certainly have a work stream for internal communication as well too, because I think that's really one of our most important focuses for this coming year is how do we start to talk to our frontline workers and people in the system about health networks, and how can we all take the good stuff that's going on across the province and bring that thinking into health network development, and how do we start engaging people, and as Dr. Hansia said, starting to think about that culture shift that we need to do to really be successful in health network development. So
I think along the communication vein, you also have just recently launched a website that people can access. So we'll share the link to that website in the chat here, so you can take a peek at that after the session as well for what is currently on there and future updates as we move along. So more of a logistical question. Does this mean getting all physicians, NPs, and allied health professionals of the SHA on the same EMR?
I mean, that might be a someday dream, but it's about how do we get people on common systems that speak to each other, maybe in the interim. I know there's work going on about interoperability between systems so that data can be shared and that we can have a shared care plan, and there's work going on to create that right now. Ideally, we would have one common system for every single person who needs to provide patient information into an electronic system. Obviously, we're not there yet, and obviously there's a lot of cost involved in that. Right now, though, the focus is on how do we make the systems that we do have speak to each other in a way that allows for the flow of information. And I think that there's more that could be done in that regard to better share the information that we have, so that no matter who you are that's seeing that patient, there's a way to record that and also access the other information from the other members of the team.
And I would agree with that. I absolutely, I'm one of the biggest dreamers or proponents of one patient, one record. I completely agree with that. I also just want to make the point that the technology is really important, but the technology just enables what we already do. And so it isn't the process, it's just an automation of the process. So my point there is that the fact that we don't have that yet and that we're working towards that and maybe sometime away from a single health record is not it's not something that will stop the process of health network development, because it's really about that team-based care, and whether that's recorded on a sheet of paper, that shared care plan, whether it's on a single health record, or whether it's on, papyrus, doesn't really matter that much. It's about the teaming. It definitely will aid efficiency and make things easier, but it's definitely not something that stops the progression of health network development.
Great, thank you for your comments. Another insight and a question. Healthcare providers who don't know each other, for example, the doctor and dietitian in Jack's story, seem like a problem of more urban centers, while more rural and remote settings struggle with having the capacity to meet the needs of patients and community. How will the establishment of health networks address the distribution of healthcare resources and improvement of health equity?
I think, one of the benefits that we have is when we established these geographies, they weren't, just someone dreaming them up in a room and deciding to draw lines on a map. We took a lot of data input into that, and a lot of that was population and public health data. So looking at the determinants of health, disease burden, but also healthcare utilization and so on. And then we took that out to some community leaders and some providers and so on, and validated that. But now that we've broken it down into these geographic units, we'll be collecting data based on that, and I think we'll have better data than what we previously had that could drill down into small area geography, which is the smaller unit that would comprise a network, to really know what the team needs to support the patients there in terms of their complement of providers and how we could achieve that. So in rural, it might mean better utilization of remote presence technology for people to join into the teams and be able to provide services, but using the data that we'll now have, we'll be able to determine what the needs are, and in a way that we can build a stronger case for that as well, because as we learn and as we work together better, we might be able to actually work more efficiently as well and have people working to their full scope and really have the skill task alignment of the professionals that we do have to best meet the needs of the patients. And once we do that, where are we still not meeting the needs? And then being able to demonstrate that there's data to support that we're not meeting the needs. We've changed the way that we work to work more collaboratively and efficiently, and we're still not meeting the needs, and then we need maybe another provider or need to link another provider into this team from another team or whatnot. So there's a whole process that we can now go through to identify those needs, I think, in a more coordinated way than perhaps in the past, where it's been, the sense of the team that we probably need this service, so it's added on in layers onto the complement of different options that might exist for patients.
Thank you, Dr. Wasko. I see a vein of questions that are wanting to dig into the specifics, so maybe I'll address this question to you, Sheila, and you can speak from experience in Regina. One question is, what specific steps need to be taken by primary care providers to achieve this? What about specific practices that provide services to a particular patient population? Is there an example that stands out in your mind that you could kind of walk us through of how that's unfolded in Regina?
Sure. Thanks, Chelsea. So in terms of some specific examples of primary healthcare providers in the Regina area that have worked differently since the implementation of Health Network. So Dr. Hansia did mention fundamental, change in what we experienced in Regina was how people and our providers team differently. So it's that health networks are a geographical area where providers are responsible for the specific, are accountable and responsible for the people that reside within that geographical area. So it happens in urban, obviously, that a number of neighborhoods make up an individual network. Here in Regina, we happen to have 4 networks. So the way our individual primary healthcare providers are teaming together is different than they have in the past. So we obviously have primary healthcare services or community services like most of the province have around public health services, home care services, our palliative care teams, our chronic disease management teams. And in the past, those teams have worked really quite in silos. So when a team needed to refer to one team to the other, they certainly did that through some type of a referral process. What we've now got to the point, we're 4 or 5 years into implementation in Regina. Sounds like a long time, but still, I would say, still very new and in our infancy in health network development. But those teams now work together at a network level. So, for instance, we have home care providers, this is just a very simple example, who are calling into their local primary health care clinic to see if they can get access to maybe a chronic disease management nurse that works in there because their COPD is exacerbating, for instance. We have a number of providers out in our networks who are now embedded in doing visiting services in physicians' offices, providing chronic disease management. And I do think that it has been a common practice across the province, so I'm not suggesting that is something that's new and unique to health networks, but what's new and unique is that particular person that may have COPD or diabetes or some other chronic illness, they're providers that are going into their home, so their home care, their nurses, their care aides are now connected to their respiratory therapist who then visits them once a week, who's also connected to their physician as well. And one of the other things that we realized through data and through understanding the unique needs of each one of our neighborhoods and networks was a real gap in Regina around what we call intermediate care services, if you're familiar with that term. So that's really being able to have the ability to have the right type of providers and the availability of those providers to provide a bit of an intermediate care, so that's kind of complex care out in the community. We certainly could see through data analysis in Regina that many people were sitting in our acute care services our acute care facilities who actually had complex and intermediate care needs that actually could be managed out in the community if we had providers that were able to do that. So one of the things that we were able to do was establish a community paramedicine program that really bridged the gap between people that maybe even either coming out of the acute care system and when they were still had some complex or intermediate care needs before or together connecting them back to their primary health care providers, or really we've been very successful about trying to use our intermediate care teams to prevent admissions into the hospital as well too. So those are just some examples that I can think about that, and those intermediate care teams, so we have a few paramedics and a nurse practitioner, pharmacist, et cetera. They work integrated into each one of our networks with those primary healthcare providers and those community frontline workers that I kind of spoke about. They're integrated into that team, so as if you're out in the community working and you have a patient that you know very well, that you know is escalating, in addition to always contacting their family physician and making sure that we're aligning with the care plan with our family physicians. We also have other resources in the community now that we're going to be able to support keeping that client or that patient in their community as long as possible, cared for appropriately.
Great, thanks, Sheila. So as I read through the questions, I'm trying to pull some that we haven't kind of touched on in responses to date. So I apologize if you don't see your question specifically represented in the Q&A. It's because I felt that perhaps we've addressed it through some of the answers already. So the next one that I'm going to pose is just unpacking some of the language that we're using. So can you tell us a little bit about the practical differences from a patient's perspective between a community health center and a doctor's office?
So, I mean, we have examples of community health centers where teams may already be more multidisciplinary. So we might have different health professionals co-located under one roof. As I said earlier, that doesn't necessarily mean you have integrated services, though. It's a way that could facilitate that. I mean, obviously, if you're working side by side, it should be easier to have integrated care, but we all know that doesn't necessarily happen. And then there are cases where there are, a solo GP clinic that exists, and no matter, where it is that a patient receives their everyday health services, the goal is that the health network surrounding those different locations would be supported to better meet the needs of the patient. The way that we're moving is to have more co-located teams that could wrap around patients, but that's not the way our system currently works, and we don't need to wait until that occurs for us to better support the people providing care. So that's kind of why we've given different examples of where it might be that patients seek out their everyday health services most of the time.
Great. Thanks for that, Dr. Wasko. Our next question is a little bit about the finances, so where the dollars are being allocated. Can you comment on the extent to which fee-for-service models helps or hinders the development of team-based patient-focused care and the culture change needed? What are the incentives for fee-for-service physicians to participate in the networks? If not, are financial incentives being contemplated? So there's a lot to that question. If you want to break it into chunks, we can address it in multiple.
Yeah, so that's a very that's a challenging question for sure. I think one of the things that since coming into being 2 years ago as an SHA that we've been trying to say is that there was this idea that primary health care was delivered by, a physician that was on a contract that had to work in a model with a nurse practitioner and be funded by the health region that they worked in. And then there were private fee-for-service doctors, and they are not primary health care doctors. And that's really something that we would like to move away from in terms of language. All family physicians provide primary health care, and all primary health care involves a family physician, ideally as part of a team. How we structure teams is different based on the patient need, but the goal is really to have a team that cares for the patient, and that family physicians, regardless of how they're paid, are an important part of that team, and in many cases lead the care plan of the team. There are certain models of payment that may lend themselves to more team-based care, though, and we know that to be true, that there are challenges with a fee-for-service model because it doesn't build in that type of remuneration to work with other health professionals on case conferences or whatnot all of the time. There are some fee codes that could allow for that, but they're limited. I know that these are discussions that are occurring right now between the Ministry of Health and the Saskatchewan Medical Association about, how we better support fee-for-service physicians to involve themselves in team-based care. The College of Family Physicians of Canada, in their patient's medical home vision document, actually advocate for a blended payment model so that could best facilitate team-based care. So but I guess I'm rambling a bit, but this is not about payment, it's about team. And yes, in some instances it might be easier to build teams because payment models can prohibit that, but I think that it's something that we can work through by identifying that all team members are important. So it shouldn't matter how you're paid in terms of your involvement in team-based care. I don't know if Rashaad and Sheila have anything more to add to that. But.
No, I think you described it perfectly. It's not dependent on certain models of remuneration. Certainly assist or make it more difficult to practice in teams, and that's a huge issue in its own right. But just like electronic medical records are not, health networks don't stand or fall by just having that. Similarly, whatever the remuneration model that a physician gets paid by, their patients are still seen by different team members. What Health Networks does, irrespective of the remuneration model, is they allow those team members to work better together, and that benefits physicians as well as other team members, and definitely benefits patients.
Great, thank you so much. So I think we have time for one more question. I'm going to choose this one. How do the Truth and Reconciliation calls to action fit into this vision? Where does Aboriginal healing practices and treatment fit in?
So we have engaged with our First Nations and Métis partners to bring this message out to the First Nation communities and receive feedback. And we've had involvement and representation in some of the high-level discussions around this. There would be communities where there would be a significant proportion of First Nations or Métis populations where there would be benefit from having some traditional healing practices integrated as part of a care team. And so that is work that's underway. I mean, there would be other communities where that might not be a need, but that would be similar to other care providers as well. So there is intention and thought and plans for this, and there's an engagement strategy for our First Nations and Métis partners around health networks and how those communities and populations feel that they can better have their needs met as close to home as possible as well, and then that gets integrated into what the model actually looks like and what the composition of the team looks like too. I don't know, Sheila or Rashaad, you have to add?
Yeah. I just wanted to add too that when we think about the TRC calls to action, the health calls to action, where we're asked to close the gap between health outcomes between Indigenous and non-Indigenous people. I think the health networks really speak back to the model of health networks where we're understanding what are those social determinants of health, neighborhood by neighborhood, RM by RM, network by network, then really realigning our resources and understanding how we can create those healthy communities that we know that are really the foundation. We often talk about health networks as the opportunity to avoid ER visits or admissions into our hospital, but really we need to think that health networks are really the opportunity to really address the social determinants of health across our province and really move to those healthy communities and really impacting and improving population health ultimately. So.
Great. I think that's a great note to end on to bring our Q&A session to a close. So thank you very much to our panelists for taking the time and for using QI Power Hour as a platform to share this great work. It's been really exciting to see this work unfold and hear about it where we're currently at. So I know that we had a ton of questions today. Thank you so much for your participation to everyone who has taken the time out of their day to join us. I know that we didn't get to all of our questions, but we do just want to provide the name of the gal who has all the answers. Sorry, Adrian, I know you're on the call and might disagree with that, but she does welcome you to submit your questions to her. She'd love to hear from you and to continue on the conversation to let you know what we know to date about health networks. So I'll just take the last couple of minutes to wrap up. So for those of you who are regular QI Power Hour attenders, you will know that we've upped our game here, and we have enticed our speakers to come with these lovely pairs of I Love QI socks. So as a token of thanks, these will be on your way to a mailbox near you. Thank you for joining us today. If you too would like to become a QI Power Hour speaker and get your hands on these lovely socks, we invite you to submit your name and your topic as an opportunity to continue our conversation here on QI Power Hour and to share what you know with our community of learners. So this is our last session for 2019, but we will be excited to join you again in 2020 with an all-new lineup of speakers. What will be coming to your inbox in December is our top picks of our favorite sessions from 2019. So we invite you to sign up to our distribution list to receive that, as well as invites to all of our upcoming sessions in 2020. So with that, I just want to take the opportunity again to thank our panelists and to thank all of our participants today. Thanks for making the time, and thanks for helping us set a new record on QI Power Hour. We'll talk to you again soon. Take care, everyone.